Next case is a 64 years old woman, and during a systematic CT scan for osteopenia, an heterogeneous mass of the liver and a pancreatic mass were discovered. Tumoral blood markers were normal, and so EUS for diagnosis and EUS FNA for this mass will be performed. Oopla. Here on CT scan you can see the pancreatic mass and the liver mass with calcification. No dilation of pancreatic duct, but the mass is in the tail. So let's move an endoscopic room.
So this is an interesting case because this you saw the CT when we saw the CT yesterday. There were two very distinct round, large lesions, one in the tail, one in the liver, and so we were wondering what could, and they looked calcified on the periphery. So in this case, I'll show you. We'll start again at the liver, and I'm torquing again from the center of the liver. There's the portal vein. Learn how to do this. It's very easy. There's the portal vein. By the way, you can see the bile duct next to the portal vein here, going towards the head of the pancreas, all from the stomach. I can tell you right now, you can see the liver lesion here. Okay, so here's the liver lesion, which is huge, and definitely looks solid. And it doesn't look calcified to me. I see no calcifications. So anyway, there's the liver lesion.
Can I ask you, were there any other, can I ask you a question? Were there any other phases of the CT available? Was there pre-enhanced
that I don't know, unfortunately. I don't know. So maybe you can ask somebody else, one of the fellows. So I'm going to keep looking at the pancreas now. So here's the confluence, as I said for the first case. Here's the genu. So I'm going to torque right and follow the genu out to the tail. So here's pancreas. And as we come back, keeping the pancreatic duct, which is right here in view, that's your landmark to let you know you're in the pancreas. We come back, and here we find the tail lesion. Now, much to my surprise, here's this fairly well encapsulated microcystic tail lesion, which again doesn't look calcified, which looks like a typical microcystic adenoma. Typical. So it looks nothing like the liver lesion, which looked clearly solid. So we're going to do some contrast.
Let's try also the usual Doppler, and you can see it's really vascular. So you see, only with the usual Doppler you can appreciate that it's a highly vascular lesion. So we'll see how it looks with the contrast. One of the problems with Doppler is that there are a lot of artifacts. So if you see if anand moves a little bit, then you see a lot of flashing artifacts. So then we will try to change it again. We have a nice system here. It's an Ascendus system, so it's a really nice resolution. So we will try to change it towards the contrast again, the low mechanical index mode. So we will use again an alternate image with both images. So the grayscale image on the right and the contrast image on the left. And again, I would set up the low mechanical index at 0.2, and then you don't need to see anything on the contrast. So we will just follow the microbubbles.
Okay.
So now we're ready with the SonoView. So we will inject in bolus 4.8 milliliters. And then we will try to see what happens. Okay, so start. So we start.
SonoView is in. How many seconds should it take?
It's usually taking 10-15 seconds until it reaches the pancreas. For the pancreas, there are two phases, so you can see it already. So it's in the early arterial phase. We are now in the early arterial phase, and then we will slowly go towards the venous phase. So for the pancreas, there are only two phases. So it's completely different as compared to the liver examinations. So it's an early arterial phase, and then it's a late venous phase. But this is a highly vascular lesion, so it's also consistent with the diagnosis of serous cystadenoma. So
if the Doppler is positive, what does the SonoView add?
Yeah, it adds when the Doppler is not positive,
Okay, so
let's
if it's
say.
positive,
So
it's
yeah,
not really
so if it's
necessary.
positive, it's not necessary.
Okay.
But on the other hand, you don't have artifacts now. So what you see is only microbubbles in
Right.
the vessels,
Okay.
and you don't see only. You see also. So first a macrovascular phase and then a microvascular phase. So first you see the big vessels, and then you see the microvasculature, so the
Okay.
capillaries. So you cannot see that with Doppler. So with Doppler
Okay.
you see only the big vessels, but this enhanced almost completely. So
Yeah.
now you can see that it's almost a complete enhancement of the lesion.
So who would do FNA?
So
I have a question.
Yes.
yeah.
I have a question.
Yes.
Hi, Anand, Shamila
Hi.
here.
Oh, hi, how are
I
you?
just want to find whether a possibility of a neuroendocrine tumor with this kind of image.
It's always a possibility, but to me this is too, just looking at it macroscopic, without the contrast, it looks too microcystic to be a neuroendocrine tumor, but then for the contrast also that helps, I imagine?
Yeah, but also most of the neuroendocrine tumors are hypervascular, but what they do, they usually wash out in the late venous phase. So what you see now is that the contrast is still there. We are almost at 2 minutes. So neuroendocrine, especially malignant neuroendocrine tumors, they wash out pretty fast. So they have a burst in the arterial phase, and then in the venous phase they usually wash out. So that's one of the criteria. But could you please move on the liver, Anand,
Yeah,
just a
okay.
little bit, so we can use the contrast. The contrast lasts for about 5 minutes, so we can use the contrast and look on the
This
liver
is the liver
mass.
lesion
Yeah.
here.
But also if you yeah, we can re-inject.
By the
or-
way, Sharmila, another sign that to me it's not a neuroendocrine tumor is that a tumor this large would almost invariably cause pancreatic duct obstruction, and the duct proximal to this lesion is not obstructed.
Could you please try to get another section where we
Abnormal.
also have a normal parenchyma, if it's possible?
Yeah.
I know the lesion is really big, but maybe we can also see in the first images there
Here's
were
some calcifications, see?
yeah, in the periphery. Yeah.
So I think there may be some normal liver over here, I'm not sure. It's not a... I might be able to get more from the bulb as well. This part here may be more normal. That's the
Yeah,
pancreas.
that's the pancreas, but maybe
I saw here's.
on
See,
the
I think this
edge,
is the
so-
border of the lesion here, so I think there should be some normal liver here. Yes.
Anna, there aren't probably many radiologists here, but most of them who are here will be thinking this is a fairly obvious giant hemangioma in the liver.
yeah, we can try that with contrast, see if it works. Yeah.
I think contrast would be very useful to see a centripetal flow,
Okay.
filling in as a lesion as you go, but you're already going to be in an
just
equilibrium
one moment.
phase, so we need to...
Yeah, we're doing another shot of contrast.
Yeah, we will try in the liver lesion. So just a moment. Okay, now I think. So you still see some of the contrast from the previous examination, but I will decrease a bit the gain. So now,
Should we go?
yeah.
Allez-y.
So we will try a second vial of Sonoview, again 4.8 milliliters.
Okay.
So we started.
contrast is in.
We will start the timer. So now you see the timer,
Oh,
and
there's
now
a
we
timer.
can. Yeah.
Is it extra?
In the
Does it
right.
cost extra, the timer?
I don't know.
It's probably like only $15,000, $20,000.
Yeah, something like that. So now you see the contrast. It's in the. There is some inside the lesion. So yeah, it's in the periphery. So.
Yeah.
It might be a hemangioma, I agree. So now you see it starts to fill slowly, but we can wait. So sometimes for hemangioma you have to wait 5 minutes or even longer. So that's one of the limitations of contrast.
I'm trying to go more over it so you can see if it's going towards the center.
There were some areas where you see some of the areas
Yeah.
are filling slowly.
Interesting.
The trouble is also, the larger the hemangioma, the more atypical can be its behavior.
Yeah, and
Right.
they usually enhance very slow, so that's one of the limitations of Sonoview, because after 5-6 minutes you lose the contrast. So then with a CT, you can do a late phase examination, which is really longer. So that's one of the disadvantages of contrast for the liver, the US, the Sonoview.
They say it looks like a hemangioma. Yeah. And she's already been biopsied, right? So I think, okay. Combien de temps? Okay, so
I can.
We're off now. I'm off. There we go. Okay. Are there any questions? I don't think we'll biopsy this. This actually was biopsied previously, and it showed just inflammatory cells and certainly nothing malignant.